excited to have Robin Stone here to talk about the long-term care workforce. Robin is a noted researcher and leading international authority on aging and long-term care policy. She directs the Leading Age Center for Applied Research. She came to Leading Age from Longevity Center USA in New York, where she was also the executive director. She previously worked at AHRQ, the Agency for Healthcare Research and Quality. She served in the White House as Deputy Assistant Secretary for Disability, Aging, and Long-Term Care Policy, and as Acting Assistant Secretary for Aging in the U.S. Department of Health and Human Services under the Clinton administration. And prior to that, she's worked at the National Center for Health Services as well as Project Hope Center for Health Affairs. She was on the Hill in the 1989 Bipartisan Commission on Comprehensive Health and the 1933 Clinton Administration Task Force on Healthcare Reform. Robin has been around.
I know.
She has been there. She holds a doctorate in public health from the University of California at Berkeley, and we're very fortunate to have her here in Washington, D.C. as a neighbor and to have her here today.
I have been very committed to the direct care workforce in long-term services and supports for quite a long time. In the early 80s, I started doing some research on informal caregiving in long-term care, and shortly after that, it occurred to me that in addition to the family, it was really the Frontline that was doing the lion's share of the work in long-term services and supports in particular. And then in the late 80s, we had a serious issue because the economy got better after a recession, and everybody started leaving their jobs. So there was hue and cry around the workforce. And it's interesting, if you time interest in workforce, it has typically been tied to better economies following a crash in economies. I'm hoping that that's going to change, partly because of demographics, where we're seeing that there's potential for a more long-term shortage of particularly frontline workers over the next 25 years as we see the population aging. But more importantly, that we move away from just warm bodies and think about quality. So my focus and the focus of my organization over the past 15 years, and we started looking at workforce issues from the time that I got to Leading Age, which is a National Association of Aging Services Providers, about 6,000 members. And they, of course, have a vested interest in this because they are the employers of much of this workforce. So almost 15 years ago, we really started working on how do we support and sustain a quality long-term services and supports workforce. That's really how I got into this. It's not from a workforce development perspective per se, it's really from a quality perspective, because I make the argument that there's a three-legged stool in healthcare. There's financing, there's the magic delivery system, and then there's the human capital that actually makes up the vast majority of the system. And despite our efforts to always find the panacea, including the electronic health record and some of the technology that seems to be the buzzword these days, human capital is really, really important in healthcare writ large, and certainly in long-term services and supports. About 80% of all hands-on services are provided by frontline workers, whether they're certified nursing assistants in nursing homes, assisted living, home health aides, and home care and personal care aides. So next to the family, they're the most important provider. And that has been a focus of both our empirical work at Leading Age as well as some of our advocacy. And most recently, I've been involved in the future of home care. It is a growing area. It is one of the fastest growing areas in the healthcare sector, and it is one of the fastest growing jobs in the country. If you look at economic drivers in many communities, it's the service industry, and within that service industry, home care is growing by leaps and bounds. What we don't know about is the quality of that home care and the quality of the workforce. And so we are trying to shine a light on that, which is why I titled this talk, Not Your Grandmother's Home Care Aide. Because the question really is, as we look at a sector that is focusing both on efficiency and effectiveness as well as quality, and practicing to the highest level of your skill sets, what is the potential for home care aides to actually be an integral part of the system, care teams, and responsibility? So we sort of start with that perspective: growth in this area, jobs, the development of viable jobs, and issues around competency and quality, both for the worker herself, but also for the outcomes to the people that are being cared for. And the demographics right now, depending on the data set that you look at, there may be 2.3 to 2.5 million direct care workers. A large percentage of those are home care workers or personal care attendants. These are not necessarily home health aides. They may not be certified as a home health aide worker, in which case they do not have any federal requirements for training. So we have large numbers of people who are providing care in the home, both instrumental activities of daily living, personal care, and I would argue that there's a lot of observation going on, not assessment, but clearly these are the eyes and ears of the system. So if you have one person in somebody's home for the vast majority of the time, that's the individual that actually picks up changes in condition, problems, and the environmental context within which somebody is living, including the physical environment as well as sometimes the social environment. So issues around isolation, issues around family dynamics. The home care aide and personal care aides are privy to quite a bit of good information and bad information. And the question for those of us who are interested in this part of the workforce is, how do we think about developing these jobs over the next 25 years as we see the demand really escalating? And that, of course, comes from a number of different things. First is preference for people to remain in their own homes. Now, I think occasionally and often that's a specious preference, partly because people may not afford to be able to remain in their homes and hire the kind of caregivers that they need. It also may be that it isn't the best place for them, partly because they may be living in a home that is falling down around them, or they can no longer afford to remain in their own homes because they may own their own home outright, but the property taxes are astronomically high, or they need to repair their roof, or their stairs are falling down. So there are all kinds of issues that suggest that this sort of rhetoric around home is always the best place is not always the best place. But having said that, we have seen a tremendous movement in the direction of more home and community-based alternatives. That has been enhanced by certainly Medicaid expansion in a number of states that have both supported more home and community-based services, and also money follows the person, where there's actually dollars that have been focused on getting people out of nursing homes and back into the community, or diverting them from nursing homes altogether. In addition to that, we see a heavy emphasis on very quick hospitalization and return home to the community, in which case you have more home health and home-based programs going into the home, often relying heavily on aides as part of an interdisciplinary team. So the expansion and the exponential growth of this, and we don't even know what this is going to look like over the next 20, 25 years. But what we do know are a couple of things. We have increased childlessness among middle-aged and older adults. We have increased divorce rates. We have women who are staying in the labor force longer, including past 65. That's the fastest growing part of the female labor force. Some of that by choice, some of that because they can't afford to retire. All of this is going to put substantial burdens on a fairly fragile informal caregiving system. And so the real question, and there's a new book out, and you're probably going to ask me for the name of it, but I can't remember it. All I can tell you is I have a chapter in it that talks about all of these demographics, but we are probably going to see a decline in the availability of informal care. At the same time, we are going to see a shortage of the females in particular who are in the age group that would be most likely to be the direct care workers. So we've got a number of sort of demographic factors coming together to sort of create this crisis, if you will, but also an opportunity for thinking about moving away from this notion of warm bodies and thinking about how do we actually develop these jobs, make them viable, make them financially viable, create the infrastructure to support them, and the training necessary to actually have skilled professional people coming into individuals' homes, and perhaps setting up certification competencies that not only agencies can look to, but that families can look to. Right now, you know, Polly talked about offline, she was talking about sitters who are going in to help with elders who are in hospitals or when they go home. What are the qualifications of these sitters? Now, maybe they were hired to sit, literally to babysit, I'm going to put that in quotes, with an elder, because that's what the family thinks that person needs. But in fact, they are the eyes and ears of the system. God forbid something should happen. We have untrained, vulnerable individuals in people's homes or even in the hospital setting, not knowing what to do, not having an infrastructure to support them. We're one step away from either an abuse allegation or a legal situation. And while I believe that there's a lot of abuse that does go on in communities, I think there's also a lot of exploitation of the workforce. We don't talk a lot about worker abuse. So all of these things, the growth in home care, the expansion of post-acute care, the preferences of for people to remain in the community for as long as possible, and the expansion of this job category as one of the most fastest growing in communities around the country actually really put a highlight, really shine a light on this occupation. And that's why I think this is no longer our grandmother's home care aide. I think a time is going to come when we're not just hiring in the private market anybody that we can get in to come into the home. And that's not just because we are going to be more thoughtful about the skill sets that people need, but also hopefully because we're going to have a society that recognizes that this is a true profession and not just butler and maid service, which is what we used to talk about when I worked for the Pepper Commission in the 80s. And I had hoped that we had gone a lot further from there, but yesterday I was at a meeting where somebody referred to a home care aide as the help. So this, and it was a very well-meaning caregiver panel. So these are people who actually are employing aides, understand the complexity of those jobs. But the language, the nomenclature, and the issues around how do we think about creating these positions as viable professional opportunities. And not only that, but thinking about how do we make this job career ladders, career lattices, the Elder Care Workforce Alliance, which is an umbrella group of national associations that brings together a lot of both professional associations in nursing, medicine, psychology, psychiatry, social work, allied health, direct care workers through PHI and the Direct Care Alliance, but also provider organizations like Leading Age and others that employ this workforce across the spectrum, has actually worked together with a number of other organizations to create an advanced aid position that they have actually even worked on crafting some legislation around, which would begin to focus on how do we think systematically about developing these aid positions into medication management. And we can talk about that, I think, because this is really important for boards of nursing and how we would do this. Medication management, pain management, dementia specialties, integration, care coordination, infusion, all of the types of things that we see many of these folks doing actually on an ad hoc basis, and where we really want to both formalize and perhaps credentialize and actually raise rates, raise wages, raise benefits. This is not a budget neutral activity, but what it is, if we do it in a way that allows people to practice to their highest level of skills and knowledge, begins to become more efficient with the system. So, these are really important issues, I think, for the next 25 years as we see not only the elderly aging and the population aging, but the 85 and over population growing fivefold. It's not just the aging of the population. It's the growth, the tremendous growth in the 85 and over, because your demand for these types of services goes exponentially higher when you reach 80. And that's really where we're going to see a lot of these issues being driven. And it's that group, this 85 and over population, where we're going to have younger 60 and 65-year-olds who may actually be the caregivers, who are going to have to remain in the labor force longer. It used to be the sandwich generation was really talked about as middle-aged moms. But it's really, a lot of this is going to fall on the shoulders of young old. So how do we think about this? What are the solutions for this? What are the solutions both for training as well as pipeline? So it's actually recruitment and retention. It's training of the pipeline. It's training of the incumbent workforce. We've got all of these issues that are parts and parcel of a systemic notion of investment. For a number of years, I was on the Department of Labor's Commission on Apprenticeship Programs. And we talked offline about a former MHA student here, Carissa Rayner, who now runs the Washington State program, home care training program in Washington State. She also happens to be on this commission and was on it with me. But one of the reasons we have been on the commission was that in the 21st century, apprenticeship is being seen as not your traditional trade jobs, but also new jobs in information technology and in healthcare. And one of the potentially viable tracks there is home care and personal care. The struggle that we have had in getting this really adopted as a particular path for apprenticeship is that there's not enough money in the system in terms of compensation to make these jobs eligible for a formal apprenticeship program. So we're sort of in this catch-22 situation because we want to be developing these jobs, but we want to be developing viable jobs. And in our sector, many of these jobs are tied so heavily to public payment. So in the trades, for example, You have jobs where electricians are making a substantial amount of money per hour, right? Plumbers, right? They've either negotiated a rate through the unions or they've negotiated with management. These jobs are recognized. In home care and in personal care, a lot of this sector has been supported by Medicare and Medicaid, where reimbursement rates are not high enough to be able to support these viable jobs at the front line. So we have to think about this workforce development as a systemic problem. It's a problem for our Medicare and Medicaid programs. And as long as we keep those reimbursement rates relatively low, and of course in Medicaid we're talking about state variation. So you may be in a state like New York where you have very relatively high Medicaid rates. Some of that is because the unions have also negotiated that, particularly in New York City. You have other states like Illinois and southern states like Mississippi where the rates are so low that it's actually impossible. I am amazed that we're actually able to get anybody to work in this sector in some of these places, except for the fact that these are the most viable jobs. These are the jobs in these communities, right? So part of it is a question of raising the minimum wage. But I think more importantly for us in healthcare, it's a question of how do we think about these jobs as real professions? And how do we think about them in terms of the skill sets, the knowledge, and the competencies that are required to do the very complex care and service that is being provided in the home today. And as we begin to lay that out, we set up a framework for these professions, and then how do we monetize that? Without that, it's really hard to go to anybody and say, you know, how do you think somebody like this can do this job for $8 an hour? Particularly when they're also raising children and a whole lot of other things. So there's a lot of ways that you can sort of skin this cat. You can really come from it from a number of different perspectives. But at the end of the day, I argue that if we're going to have a system that is built on the direct care workforce, which we absolutely have in long-term services and supports, and increasingly in the larger healthcare system, because people are being moved into the community very quickly. How do we make this work? Here's a question for you. Why are hospitals and health systems creating their whole new community health worker system? Why don't we think about relying on the home care system and the personal care system that is already out there? I can tell you that most of the workers that I know are the best community health workers you could ever find. So we're not thinking creatively about systems that are already there that could be built on. We are creating new, we are being redundant, and you know, I believe that we could take a personal care, home care aide first tier and build on that a lattice that would include specialties, that would include training around community health work, that would create training around management so that not all aides want to become a nurse. I don't know, I know we have at least one nurse in the room, but let me tell you this. Everybody says to me, well, don't we want to create career ladders for CNAs and home care workers and personal care aides? And I'm like, yes, I think we do. But not all of them want to be a nurse. Many of them like being aides, and they may actually want to be more sophisticated aides, or they're fabulous at managing people. They have the people skills that your average nurse wouldn't have if she fell over it. So why aren't we moving them into management positions? Managing home care, management in nursing homes. Why do we force a nurse to become a supervisor when that is not her skill? We don't always force it. We actually do it because we don't have anybody else. But you know, I think the thing that is so amazing about the transformations that are going on right now is that they create opportunities everywhere. The focus on community, the focus on practicing to your highest level, the focus on efficiency, the focus on integration, the focus on team-based care. All of this is an opportunity for thinking about the future of home care and personal care and how that fits into the larger set of issues and how it can become a solution instead of just a problem. And as this becomes a solution, it also becomes a viable job creator, which gets to a whole other part of our system, which is that it's about jobs. And so, we really argue that this is a way of creating viable jobs in communities if we can just sort of bring it all together and think about it. The other piece that I think is really important for us to consider is that at least 1 out of 5 of this workforce, and we don't really know because we don't know the shadow economy very well, but from the existing data that are there, we know 1 out of 5 are immigrants. And immigrants have been populating this workforce. We have some data that we just did using, unfortunately, 2007 data, because that was the most recent national data that we have from the National Nurse Home Health Assistant database that was developed in 2007. So let's see, how old is that? It's like 8 years old. On the other hand, it does give us some insights. 48% are of some type of, are African American, African, Caribbean, or some other of some other descent in that arena. 28% are of Hispanic origin. Only 16.8% of these immigrants are white, but they are of Eastern European background for the most part. And then we've got over a third that are other, including a very high proportion of Asian frontline workers, whether they're from the Philippines or from Vietnam or from some of these other East Asian countries. But we have tremendous workers from these various countries who bring not only skills, but often education, because they were trained as nurses. Some were even trained as physicians. Many were trained as pharmacists. They are practicing as aides because, in many cases, they have not been able to pass licensure here in the United States. Some of them also actually prefer to be in an aide status. But we're not thinking about how they can practice to their highest level, nor are we using their knowledge and skills to the best that we could. So I think there's a couple of things around the immigrant workforce. One is that we need to think about them more thoughtfully in terms of how they bring their skills and knowledge to bear on these jobs. But also, this is the future of our pipeline. So if we are not in the immigration policy debate, we need to be. And nobody wants to talk about that, even at leading age. I mean, we don't want to get into the dirty issues of immigration policy, but the truth is we're already in it because our workforce is in it. And not only is it in it as a domestic issue, but it's in it as an international issue because of the question of what happens to the country of origin. Some of that is great in terms of remittances that may go back to the country. Others are really problematic because we're taking workers from other countries. So this has actually become an issue that is on the radar screen of our international group, which is, we have an international organization as well as a domestic organization. So the International Association of Homes and Services for the Aging has taken up this international workforce, global workforce issue as a priority for us, in terms of the question about migration and the impact on both the country, receiving country and the country of origin, issues around ethics, issues around potential exploitation, issues around international training, and whether there needs to be standards, issues around evidence-based sharing around best practice for how we train and how we support. So it's a great time because there's a lot of chaos, but one of the things that we talk about in terms of this human capital issue is that it's a trade issue. So not only then are we talking about immigration policy, but we're talking about trade policy. And the more that we can raise these issues into the spectrum of other policy arenas, the more we get attention to this, and it no longer is just these low-wage jobs, which I think, has sort of become an albatross around our necks because it's a catch-22. How do we move out of these low-wage jobs? But again, we continue to refer to them as low-wage jobs. I always, Paraprofessional Healthcare Institute moved away from their name to PHI for a reason. Paraprofessional makes no sense whatsoever. These are not paraprofessional jobs. These are professions. And when I am in a workforce development meeting or I am in a healthcare workforce meeting and we talk about the professions and then the others, I'm like, these are all professions. And we have to be talking about them that way, and we have to be thinking about them that way.
Do you want to open it up to
Yeah,
questions?
I think that
we have about 20 minutes left.
I think that would be great. Yeah, please. Please, anybody start. I know we'll have somebody that'll talk.
I have so many things. I think an offside conversation because you hit on so many things. I lived all this for the last 10 years. My mother lived to be 101 and a half. And the last 10 years, and I'm 72 years old. And
there you go.
I was the caregiver. I mean, it just rings bells. And most of the people that helped my mother were from Africa, not the United States. And naturally, I come from a spinoff of the American National Standards Institute. I spent the last 5 years working on globalizing, framework for globalizing credentials, which rings when you talk about international standards. Over this last 10 years, and I have another project that I want to talk to you about offline, but it has become very clear to me. My mother started in assisted living. Absolutely, the gap between what they're required to do and their training is like a Grand Canyon.
It is completely.
It's unbelievable. And the same with the nursing homes, because she went from assisted living to nursing homes, and I think that these people deserve a credential. But I think that we have to go back and create better job analyses of exactly the decision-making authority. Like in assisted living, I am amazed at the sophistication that one has to have to understand the change. And when you call for help or when you don't call for help, nursing home, it's almost easier because there's more chronicity and it's more visible and concrete.
That's right.
But there's still...
Well, and think about the home care where you don't even have any infrastructure whatsoever.
Right.
You're just in somebody's home.
Yeah.
I mean, these are nightmares just constantly waiting to happen. I'm amazed that we don't have more problems, and I think it's because we have unbelievably caring people who, are just sort of able to pull it off. But I would be scared to death, as many aides are, quite honestly, because they don't have the training, they don't have the support, they don't have the money to pay for training. There isn't wonderful standardized training around. There aren't faculty to teach. I mean, we're starting to see it happen. We've got a few little bellwethers here. Finally, HRSA has now, you may not like it or you may like it, but they've put all 4 of their geriatric education programs together, and they are now, as part of the portfolio, direct care workers can be trained through these GECs and the other programs that have been brought together, as can family caregivers, which are... So there's opportunity there at the local level for folks to be working together with community colleges or universities to develop some of these training programs, but somebody's got to pay for them. And, so that, I mean, the gaps are tremendous, and our investment is so lacking. And again, I go back to the reimbursement rates. I mean, I can understand why a provider doesn't want the mandate on them, because they don't necessarily have enough resources to be able to pay for it. Although I will say they waste a lot of money on the training that they're doing now. And I think that they could look at their budgets and be reusing a lot of the money that they don't. I have no idea whether anybody got any kind of in-service training in assisted living, but if they did, my guess is it was horrible.
Yeah.
And so,
Absolutely.
I always tell the CFOs of these organizations, look at your training budgets. You will look ad nauseum at your budget for technology, but you won't spend any time looking at your budget for your human capital, which is where most of your costs are. They're in labor. So, I think this is just an issue for us.
What's your sense of the,
Do you want to introduce
oh,
yourself?
sorry, yeah, I came in late. I'm Martha Ross from the Brookings Metropolitan Policy Program.
Oh, great.
What's your sense of the likelihood that we can make the case for higher reimbursement and higher pay based on savings down the line? Avoidable hospitalizations, avoidable ERs.
I think that's a really hard one, because the data on savings is very. I mean, we're doing some work in this right now with a model of affordable senior housing and service coordinator and wellness nurse together, and we actually have seen some savings on the Medicare side, but it is the whole team and the interaction with primary care and the better transitions out where you don't have rehospitalizations. To tie that just specifically to the frontline caregiver is a really hard thing to do. So I'm not sure that we can hold it to savings specifically to this particular category of profession. But I think if you think about the redistribution of how that team gets reimbursed, and some of this is, and this of course gets into guilds and turf and all of that, but some of this is redistribution of dollars. So it's not all new dollars. And if we had a shared savings activity where the dollars were shifted, the question is how do those dollars get redistributed?
Right.
And I think that's as hard as anything, because even if we see this right now, and this is my issue with hospital and health systems developing a whole new cadre of community health workers. Because what happens is you're just basically creating a whole new level where you have not invested in the workforce that has already been out in the community. And with an investment there, you begin to build not only the levels, but you've got the kind of career lattice and ladder that you may want. And nobody's thinking about that. So I think it's got to be a little bit more than just thinking they're savings. It's how are these dollars being used?
Right. So you can see if it's part of a larger practice redesign,
Mm-hmm.
then that it needs to be. But what I don't understand well enough is, are home care workers or direct care workers often not part of a primary care practice or the hospital? So
They're not, but
right.
no.
So how do you tie them into this practice
Well,
redesign?
It's got to be actually tied in. I mean, most primary care. I mean, the rub is that.
ACOs.
I mean, what does an ACO know about the community?
Mhm.
What are they doing? You know what they're doing? They're hiring nurses who are doing telephonic calling, which went out 20 years ago. And I know I'm being videotaped, but I have to be honest with you that the redesign is not redesigning in the community. and it requires that. Now, you're still going to have a lot of, this is not happening overnight. So you've got all kinds of morphs of this going on. Some of it is capitated, some of it is fee-for-service shared savings, some of it is just continued fee-for-service, but regardless of the payment methodology, the goal of integration is still there. So how you think about this, however you want to organize it, that frontline worker is still going to be a major person in the home.